Assalamu alaikum, everyone. My name is Dr. Muhammad Salim. I am a consultant endocrinologist at Aga Khan Hospital, Hyderabad. Today, I'm from the platform of Pakistan Endocrine Society, the society which sincerely desire to spread the knowledge of diabetes and endocrinology across Pakistan. Considering this, Pakistan Endocrine Society organized today's webinar on the PCOS, which is called Navigating the Hormonal Maze on PCOS. Today, we have two distinguished speakers, Dr. Aisha Sheikh. Dr. Aisha Sheikh is a consultant endocrinologist at Aga Khan University Hospital, Karachi. She is also a consultant endocrinologist at the South Wales, UK. She has a vast experience in diabetes and endocrine disorders. She has multiple national and international publications on endocrine disorders. She has recently published her book on subfertility, which emphasized more on the PCOS management in young females. She is currently the president of Pakistan Endocrine Society. So welcome, Dr. Aisha.
Thank you, Dr. Salim, for a kind introduction.
So we have another speaker, Dr. Sadia Masood. Dr. Sadia will be talking about the skin manifestations of the PCOS. Dr. Sadia Masood is a consultant and a dermatologist at Aga Khan University Hospital, Karachi. She's having a wide experience of treating different types of skin disorders, and her area of interest are PCOS-related skin disorders. So welcome, Dr. Sadia.
Assalamu alaikum. Thank you for invitation.
So we all know that PCOS affected most of our young population, especially young female patients. And some studies suggested that more than 50% of young females are being affected by PCOS and other hormonal disorders. So, Doctor, I would like to invite Dr. Aisha Sheikh to start her presentation, and she will be discussing her challenging cases on polycystic ovarian syndrome. So, Dr. Aisha.
Thank you, Salim. Bismillahirrahmanirrahim. As-salatu wassalamu ala khatamil nabiyyin. Let me just share my screen. And assalamu alaikum to all our participants. Thank you very much for your presence in today's session. So what we'll do is that we'll go through complex challenging cases of PCOS that are occurring across the lifespan. So, Dr. Salim, can you confirm you can see my slide deck?
Yes, Dr. Aisha.
Okay.
Yes, everyone can see your slides.
Thank you very much. So, what we'll do is that I'll take you through certain cases of polycystic ovarian syndrome, and then we can see how the diagnostic challenges are there, how are working the web, and how are we managing these kind of cases. So, this is a 21-year-old lady. Who presents, she is single. She presents with histopolygomenorrhea, hirsutism, and progressive weight gain. Her cycles were irregular for 1 year post-menarche, and the menarche occurred at age 12. But afterwards, these cycles were regular. She noticed irregular cycles for last 3 years. She had only 5 to 6 cycles during last 1 year. On examination, her BMI is 27. Blood pressure is 132 by 85. Her Ferriman and Galvez score is 13. There is acne, no stigmata of Cushing syndrome, and no features of virilization. She has brought with her a pelvic ultrasound, which is done by her GP, that shows polycystic ovary morphology. So, IT support, can you please open the chat box for our audience, attendees? So, how many of you think that she has got PCOS? You can just write yes or no, or why or no. So you can use the chat box. Okay, so we'll just wait for a couple of seconds before we can get others opinion as well. So how many of you think that this patient has got PCOS? Okay, thank you very much. So we'll move on to the next slide here. So remember, when we are managing somebody with oligomenorrhea or features of hyperandrogenism, I need to be sure what kind of menstrual irregularity that patient is having. So when we are defining menstrual irregularity, remember, 1 year post-menarche during the pubertal transition, irregular menstrual cycles are expected, and this is a normal phenomena. This is occurring because the hypothalamic pituitary ovarian axis takes this much time to attain maturity, sufficient enough to have regular menstrual cycles. Okay, then 1 to less than 3 year post-menarche, any cycle which is less than 21 days or any cycle which is longer than 45 days would be considered as irregular menstrual cycle. Similarly, 3 years post-menarche to perimenopause, that is less than 21 days cycle length or more than 35 days cycle length or less than 8 cycles per year will be considered an irregular menstrual cycle. Similarly, if 1 year post-menarche, the woman or a girl has a cycle which is longer than 90 days duration, that is considered irregular as well. Primary amenorrhea, on the other hand, is defined by absence of menarche by age of 15 years or more than 3 years post-menarche. So the girl entered puberty and had pubertal stage 1, where she had the breastbed appearance, but did not went into menarche 3 years since her onset of menarche. So to better define menstrual irregularities, it is always important to have ask our patients to have their menstrual calendar available, because that tells us very well what kind of menstrual cycles, what kind of abnormality or irregularity we are having. Similarly, a single menstrual irregularity does not matter much unless there is a recurrent phenomena or there is a pattern that is occurring on a regular or periodic basis. The other thing is clinical or biochemical hyperandrogenism, and you'll be hearing more on this in Dr. Sadia's talk. Androgenic alopecia or female pattern alopecia, similarly acne and hirsutism, which is the N terminal here in a male pattern. Similarly, the biochemical hyperandrogenism is evident by a high free androgen index level, calculated free testosterone level, or calculated bioavailable testosterone level. Remember, in Pakistan, we have only got free androgen index available to us. But in centers where there is bioavailable testosterone available, that can be done. So an elevated level would actually tell you that there is biochemical hyperandrogenism. Remember, if the testosterone levels are normal, having additional tests of androstenedione or dihydroxyandrosterone does not add much to the information and should ideally be avoided. The other criteria is polycystic ovarian morphology on ultrasound. So you can see that more than 20 follicles per one ovary or ovarian volume of more than 10 ml or with no popular uterus cyst or dominant follicle in either of the ovaries. And this is the typical appearance of a polycystic ovarian morphology on ultrasound. So remember, avoid labeling PCOS in adolescents and when diagnostic criteria is not complete. And we just go through different criteria that is available for diagnosing PCOS, because it's a syndrome. You need certain things in to be present in unison or together before you can label somebody as having PCOS. So there are various criteria, the 1990 NIH criteria, the androgen access society criteria, and the Rotterdam criteria. And Rotterdam criteria is something which is more in use throughout the globe. And even in our centers and our practices, we use the Rotterdam criteria more often. So this criteria includes oligo and anovulation that will be evident by oligomenorrhea or amenorrhea in the patient's history. Similarly, hyperandrogenism or hyperandrogenemia, which is evident by medical or biochemical hyperandrogenism or hyperandrogenemia. And then polycystic ovarian morphology and ultrasound. And this is something which is coming up new, which is the elevated anti-mammalian hormone levels in women. So either a woman could be having PCOS morphology or an elevated anti-mammalian hormone level that would be sufficient to label as one criteria. So remember, you need 2 out of these 3 criteria to be present at one point in time when you label somebody as having PCOS. But all these 3 criteria require exclusion of other endocrinopathologies as well. And you can see that both other criteria, the NIH criteria and androgen access criteria, specifically mention about use of presence of anovulation or hyperandrogenism and hyperandrogenemia in a patient. Similarly, in adolescents, you require both you will rule out Cushing's syndrome if there is a clinical suspicion. Similarly, remember non-classic CH or non-classic congenital adrenal hyperplasia is something that needs to be ruled out, especially if the menstrual irregularities are right since menarche. Check TSH to rule out hypothyroidism, and if there is a rapid evolution of symptoms and signs of virilization, then rule out an androgen secreting neoplasm as well. Take a detailed drug history because many drugs can lead to features which are consistent with PCOS. Remember, not everything is PCOS. If there is predominant amenorrhea, rule out pregnancy. Check their LH, FSH, and estradiol levels. Look for functional hypothalamic amenorrhea, especially in somebody who is a rapid weight loss history or has athletic tendencies. Obesity-associated hyperandrogenic anovulation is another definite entity and would be seen most often because of the obesity pandemic as well. And then ovarian hypertrichosis, which is mostly seen in middle-aged women. Coming to our case 2. So this is a 23-year-old lady, single, referred by a dermatologist. She is having hypothyroidism for last 9 years, acne, hirsutism, oligomenorrhea, history of 6 cycles per year. So you can just recall that less than 8 cycles per year would actually qualify for oligomenorrhea. And then she had her menarche at age 14 years, and cycles were irregular since then. Family history of type 2 diabetes, hypertension, ischemic heart disease, and obesity are there. Her BMI, however, is 21. Her Ferryman-Galvez score is 8 to 9, which is mainly facial. And I'll just take you through the Ferryman-Galvez score. You can see that these are the 9 androgen-dependent sites where you score them from 0 to 4. 0 is no N-terminal hair, and 4 is N-terminal hair in proportions that are seen in males. So if your patient is having a score 8 or above, that is consistent with hirsutism. And this hirsutism was mainly facial. So that was a main concern for her, the patient. Acne was there. Her TSH, prolactin, and 17-hydroxyprogesterones were done, which was normal. Her FSH was 4.4, LH was 9.3. Free androgen index, you can see, was elevated at 8.2. Her pelvic ultrasound showed polycystic ovarian morphology. So with the label of lean polycystic ovary syndrome or non-obese PCOS, she was given a combined oral contraceptive pills and laser treatment, offered laser treatment. So remember, lean or non-obese PCOS exist as well. Coming to our case 3, she's a 26-year-old lady having oligomenorrhea for last 3 years, history of acne, hirsutism, scalp hair loss, weight gain of 15 kg over last 5 years. Her BMI is 29.7. She wanted to start with lifestyle modification alone in the beginning, lost 7 kg of weight over 3 months, cycles became regular, scalp hair responded to minoxidil spray, then weight became static, and then at this stage, metformin was added in her regime. So the most common symptoms of PCOS when pregnancy is not desired, you should be offering weight management to each and every woman with PCOS. Following that, combined oral contraceptive pills is something that manages their oligomenorrhea, menstrual irregularities, acne, and hirsutism. Progesterone alone can be offered to women who have predominant amenorrhea, and these can be offered to shed off the endometrium on a timely basis. Spironolactone can be offered if combined oral contraceptive pills over 6 months duration did not result in significant improvement in hirsutism scores. Other anti-androgens can be offered as well, like finasteride and flutamide. But since of the fact that these can be associated with more side effects, these are not very much in routine practical use. Similarly, mechanical means of hair removal, including laser treatments, are offered. Dermatology referrals should be offered to these women. And insulin sensitizing agent metformin has a role in PCOS women. The benefits and contraindications of combined oral contraceptive pills should be kept in mind. Benefits include the propensity to provide contraceptive benefit in these women, similarly regularizing their menstrual cycles, improvement in acne and hirsutism. Before you proceed to assisted reproductive techniques, because see, if there is a high LH level, your assisted reproductive methods and treatments will not work effectively. Similarly, for prevention of endometrial cancers, Keep in mind the absolute contraindications of combined oral contraceptive pills, and when you're prescribing it, DVTs are one, thromboembolic disorders can occur. So if there is a history of these things, you have to avoid combined oral contraceptive pills in these women. Similarly, cerebrovascular and coronary artery disease, breast cancer, estrogen-dependent cancers, undiagnosed vaginal bleeding, liver tumors, cholestatic jaundice, abnormal NFTs, and hypersensitivity to OCPs. So you have to rule out these contraindications on the basis of her history and then offer the treatment to these women. Coming to our case 4, she's a 31-year-old lady, single, having PCOS for last 8 years. Complaints of anxiety, irritability, lethargy, lack of motivation, interest, energy, and reduced appetite. The metabolic workup shows fatty liver disease. So my question to you is, and you can use the chat box, does PCOS affect mental health? So how many think that PCOS affects mental health, and how many think that PCOS does not affect mental health? So you can use chat box. So I can see some responses over here, and you can continue to think about whether PCOS affects mental health. Thank you very much. So PCOS has been associated with higher frequency of psychological disorders compared to background population. Similarly, depressive disorders, anxiety, bipolar disorder, sexual dysfunction have all been reported in percentages which are higher than background population. Eating disorders and disordered eating can also occur in women with PCOS, and as obstructive sleep apnea is also seen in PCOS. So when you're having a woman with PCOS, think about psychological disorder, and the psychoeducation is important. Lifestyle modification is something that will help with all aspects of PCOS, not only the disease itself, through the psychological disorders as well. Treating the primary condition effectively and optimally is something that will help her. Screen for psychiatric disorders during her clinical interactions and clinic visits. Consider timely referral to your psychology, psychiatry colleagues. Psychotherapy should be offered, cognitive behavioral therapy, and if needed, drug therapy should also be undertaken. Self-help and group psychoeducation by virtue of peer support is helpful in these women to overcome these psychological disorders. Coming to our case 5. So this is a 21-year-old lady, single, diagnosed as PCOS 2 years ago, having hypothyroidism, which is adequately replaced. Her BMI is 34. She started a lifestyle modification, combined oral contraceptive pills, and metformin 850 milligrams 3 times daily. She lost 4 kg of weight over 2 months, and her BMI became 33. An option of anti-obesity medication was discussed at this time, but she wanted to continue with lifestyle modification alone. She lost another 2.5 kg over 3 months. And at this stage, since her weight became static and plateaued, she agreed to using anti-obesity medications. So she was offered orlistat to begin with, which did not show a response, followed by liraglutide, which she, however, used irregularly, but there wasn't a response in terms of improving her weight. And then she was offered semaglutide, and with semaglutide 1 milligram dose, she lost 8 kg over 5 months' time. That included dose titration period as well. And she was advised to build up to 2 milligram and lost another 7 kg over 6 months' time. Her BMI was now 27 from baseline of 34. There was no history of acne. Her Hirsutism was better, but she complains of scalp hair loss. She continued her combined oral contraceptive pills, but had to discontinue her metformin since she started experiencing dizziness and blackouts. So there's a role of insulin sensitizers and weight loss strategies in women with PCOS. Metformin especially is useful in women who are 23 or above a BMI and in high-risk ethnic groups. But there is evidence of use of metformin in non-obese PCOS as well, and especially in high-risk ethnicities like us, which are South Asians. Side effects include GI side effects, and which are dose-related and self-limiting, and consider starting with low doses and gradually increment the doses will effectively reduce those GI side effects. Metformin appears safe in long term, and we know that there's wealth of data of safe use of metformin over decades and decades published, not only from diabetes, from PCOS and fatty liver disease as well. Metformin can lead to B12 malabsorption, and that is why you need to monitor their B12 levels. Following that, anti-obesity medication should be considered wherever indicated, and lifestyle modification alone is not helping reduce their weight. And bariatric surgery in women who are uh, going to higher BMI ranges where anti-obesity medications alone are not effective as well. So my next question to all of you can use the chat box. Whom will you screen for metabolic syndrome? These are two women, both are having the same age, 22 years. Both are having oligomenorrhea, hirsutism, and PCO morphology. One has a BMI of 29, the other is having a BMI of 22. Whom will you screen for PCOS? Will you screen for the lady who is having a higher BMI, the obese PCOS? Will you screen the non-obese PCOS for metabolic syndrome? Or will you screen none, or will you screen both? Okay, so thank you for your responses. And remember, insulin resistance is something which is a hallmark in the pathophysiology of PCOS. Insulin resistance leads to increased bioavailable and free testosterone in many tissues. That leads to increased production of hormones from the ovary, dysregulated gonadotropin release from the pituitary, leads to reduced SHBG and IGF binding protein from the liver, and similarly increased DHEAS level from the adrenal gland. And all these hormonal dysregulations lead to a feed-forward cycle that maintains oligo or anovulation and hyperandrogenism. Insulin resistance leads to anovulation, endometrial cancer, impaired glucose tolerance, type 2 diabetes, gestational diabetes mellitus, cardiovascular risk factors like hypertension and dyslipidemia, and markers of cardiovascular disease like carotid artery intermedia thickness, and increased high sensitivity C-reactive protein. This is the acidosis nigricans, that is the peripheral marker of insulin resistance. How do we measure insulin sensitivity? So the test which is actually the gold standard is the hyperinsulinemic glycemic clamp technique. But this is a labor, this is something which is a lengthy, cumbersome test and is only available in research settings, cannot be used in clinical practice. So people have come up with surrogate markers to define insulin resistance in different population groups. And these require fasting glucose values and fasting insulin values. And there are mathematical calculations that are used to label somebody as having insulin resistance. So coming to our next case, this is a 26-year-old lady, PCOS for last 4 years. She is married for 1.5 years and presents with inability to conceive. Her husband is 30-year-old engineer, non-smoker, and the couple is living together. Ovulation occurred in response to letrozole 3 cycles in the past and clomiphene citrate 2 cycles, took 500 milligram metformin during ovulation induction, and now she is off all treatments currently. You can see her examination findings over here, and her OGTT was normal, there is insulin resistance. So how will you evaluate an infertile couple with PCOS? Remember, even if the woman is having PCOS in the labor, her as PCOS, you still need to evaluate the male with semen analysis, and 10% of couples will have severe male factor infertility. And that should not be forgotten, because if you just ignore this thing, you can be missing an important part of her management. In the female, history physical examination would include anatomical dysfunction, looking for anatomical dysfunction like endometriosis, pelvic inflammatory disease, or iatrogenic causes like surgery, chemotherapy, radiations, exposure in the past. Complete physical and gynecological examination should be offered, and diagnostic tests include the anti-Mullerian hormone levels, thyroid dysfunction and hypercholesterolemia should be ruled out, and thyroid ultrasonography, transvaginal ultrasonography should be offered to evaluate interfollicular count, endometrium thickness, and diagnose uterine abnormalities. So this is usually offered on day 12 of the cycle. Look out for any abnormalities in the uterus like polyps, myomas, and chlamydia malformations. Then if you are moving on to advanced fertility treatments, then you have to look for hysteroscopy, laparoscopy, and tubal patency test as well. The non-pharmacological measures include weight reduction, lifestyle modification, anti-obesity medications, and bariatric surgery. Because if you reduce weight, their scores of ovulation, their response to their medication would improve as well. If somebody is taking anti-obesity medication like semaglutide, remember, before you offer them any fertility treatment, you have to stop semaglutide at least 2 months prior to planned conception. Similarly, if she's taking liraglutide, that should be stopped at least 1 month prior to conception. If a woman has undergone bariatric surgery, wait for at least 1 year before offering fertility treatments or planned conception, because this is the time you will need for that patient to achieve a stable metabolic status. Then there are specific treatments to improve fertility, which include ovulation induction, aromatase inhibitors, letrozole being the most favored option these days, followed by antiestrogens, which have been used in the past very often, clomiphene citrate, and metformin is something, adding metformin will actually improve their ovulation rates. Following this, if the first-line treatment options did not work, one can go ahead with second-line therapeutic options, which include gonadotropin therapy plus metformin, laparoscopic ovarian drilling. If there is nothing else is working, you can offer laparoscopic drilling as well. And then third-line options that include intra vitro fertilization or intracytoplasmic sperm injection. The role of vitamin D and inositols are still unproven. Inositols can be offered to just those women who are not tolerating metformin. You can offer inositol, which might be helpful in certain situations. Coming to our next case. So this is a 31-year-old lady having subclinical hypothyroidism, PCOS with insulin resistance. She had 2 miscarriages in the past. Cutoff for thrombophilias was negative and TSH is stable, less than 2.5. So my next question is, are women with PCOS at high risk of miscarriage? You can use the chat box. Are women with PCOS at risk of miscarriage? You can use the chat box to write your responses. So thank you. I can see your responses over here. And remember, hyperandrogenism, insulin resistance, and chronic low-grade inflammation all contribute to various complications in pregnancy and increase the risk of miscarriages. Those are reported to be 3-fold higher compared to background population. Similarly, the risk of gestational diabetes mellitus, hypertensive disorders in pregnancy are almost 3-fold higher compared to background population. And similarly, small for gestational age babies, intrauterine growth restrictions are reported to be 2-fold higher. And then preterm births can be seen in PCOS. So preconception weight control is something that will help improve all these complications of pregnancy. Screen for glucose intolerance and hypertension in the preconception period and effectively manage these conditions if there. Smoking cessation should be offered, and not only the woman's smoking status, make sure she is not getting exposure to the second-hand smoke as well. Metformin for miscarriage prevention, there is a variable role and can be offered till 16 weeks of gestation. Aspirin for preeclampsia prevention in high-risk women. Adequate gestational weight gain is something that will be desired throughout pregnancy, and close fetal and maternal monitoring and intervention whenever needed. Coming to our next case, this is a 42-year-old woman, mother of 2, having PCOS and obesity. Her BMI is 39, her blood pressure is 142/95, acanthosis nigricans is there. She is having impaired fasting glucose and impaired glucose tolerance and pre-diabetes. Insulin levels are high, insulin resistance is there. Her HDL is low, her SGPT is 52. So you can see metabolic risk in PCOS, and they are at risk of subclinical and clinical cardiovascular disease. Similarly, fatty liver disease, sleep apnea are higher in these women, and monitoring and investigating for sleep apnea and then managing sleep apnea will help improve their, reduce their weight as well. And then remember that at baseline and each clinic follow visit, so this is something that needs to be monitored on regular basis in these women. Her BMI, her waist circumference, her blood pressure, her lipid profile, baseline, and every 2 years if that was normal, or maybe sooner if she gets, her weight goes up. Similarly, glucose tolerance test, if that is normal, repeat it every 2 years or earlier if there is additional risk factors identified. Similarly, impaired fasting glucose or impaired glucose tolerance, if that is there, OGTT should be repeated on an annual basis. Smoking should be, you should be offering her to quit smoking, because smoking will actually enhance all those cardiometabolic risk factors. Achieving a healthy lifestyle is something that is required in these women. Getting a nutritionist counseling, Role of low carbohydrate diet, role of Mediterranean diets are well established in PCOS women. Exercise, including not only aerobics but strength trainings as well, and fitness tracking devices, which will improve their adherence to healthy lifestyle. And similarly, smarter goals like 5210, where you look for 5 portions of fruits and vegetables, less than 2 hours of recreational use of screen in a 24-hour period, 1 hour of exercise, and 0 sugary drinks. And then smart goals. So the goal should be specific, measurable, achievable, relevant, and time bound. So if you're having a patient, you have to take her and guide her and help her through her journey of weight loss. Have goals which are realistic, have goals which are time bound, have goals which are achievable. And that should be something which is done with proper patient education, counseling, and keeping her at the center of your care. Coming to our last case, she is a 44-year-old lady, mother of 4, having last child born 10 years ago. PCOS was diagnosed 20 years ago. She is having secondary pneumonia for last 7 years, but she did not consult a doctor. She developed continuous vaginal bleeding for last 1 month and pain lower abdomen. Transvaginal scan showed an endometrial thickness of 1.5 cm. The endometrial biopsy showed endometrial hyperplasia. And this is the histopathology. Over here, you can see there is a 2 to 4-fold increased risk of endometrial hyperplasia in women with PCOS if they have predominantly secondary amenorrhea. And thus, avoiding prolonged amenorrhea is something that is important to prevent endometrial hyperplasia. Combined oral contraceptive pills or withdrawal bleeding with progesterone in those with cycles longer than 90 days is recommended. So counsel your women that even if she is not able to see you or any other doctor, and if she's having amenorrhea 3 months, she has to take her progestins to have withdrawal bleed so that that endometrial lining is shed off, and thus reducing the risk of endometrial hyperplasia and carcinoma. So what we are aware of are the reproductive, endocrine, and dermatological manifestation of PCOS. What is hiding beneath is underlying enhanced cardiometabolic risk factors that need to be monitored. Patients should be advised for those, and the PCOS is something that affects a woman across her lifespan. This is our own scholarly work, PCOS book, which we published last year through Elsevier. And this is a very good, could be a very good reference book, and it covers all aspects of PCOS that you can think about. This is a very important practical guide on PCOS by Pakistan Endocrine Society, which you can ask us, and we'll make sure that you get this book to help you understand and manage this condition better. And I take an opportunity to invite all of you to our upcoming annual meeting 2024 from October 11 to 13 at Pearl Continental Hotel, Lahore. There is a very important and very comprehensive program, scientific program. We have got speakers from around the world. A lot of international speakers are coming. We are collaborating with Society of for Endocrinology UK, with International Society of Endocrinology, similarly with SAFES, which is the South Asian Federation of Endocrine Society, and with ACE, which is the American Association of Clinical Endocrinologists. So this is something which will be a very important enlightening experience for all of you. So my invitation to all of you to attend this conference and get improve your knowledge of endocrinology. So these are my references, and I'll just conclude my presentation with the fact that love yourself enough to live a healthy lifestyle. Thank you very much. We'll take the question and answers towards the end of session.
Thank you very much, Dr. Aisha. I must say it was an excellent presentation. I think you have been through all the challenging cases, like from the diagnosis to the management of the PCOS. I think it was an excellent presentation. So the next speaker is Dr. Sadia Masood. Dr. Sadia is a consultant dermatologist at Aga Khan Hospital, Karachi. So today she is going to discuss about the dermatological manifestations of the PCOS and its management. So over to you, Dr. Sadia.
So can you see my screen? I'm able to share my screen.
I think no, we aren't.
Just allow me to share.
Okay, now we can see your screen.
Assalamu alaikum, everyone. I'm Dr. Sadia. So thank you, Dr. Aisha. I think most of the things she clearly explained about the polycystic ovarian syndrome and what are the things that you need to monitor while treating these patients. So I'm basically going to discuss about polycystic ovarian syndrome and skin, and what are the problems that most of you while treating the patient with PCOS, or you saw a different patient with PCOS, what are the things about the skin you need to monitor, and how yourself you can manage such problems. So by the end of this, I'm going to discuss the common skin disorder associated with polycystic ovarian syndrome. What are the clinical presentation of these common skin disorders, and what are the different available treatment options that we can opt for. So it's very important. Skin is the largest organ of the body, so it's a window to what is occurring inside our body. So this is the window that will tell us that if there is anything abnormal going on. So similarly, it happened with PCOS. If the patient is having PCOS, then through the skin, there are different problems that um, she's facing through, like she can be having acne, hair loss, different type of hair loss, excessive facial or body hair growth, dark patches on the skin, or sometimes the patient present with combination of all these symptoms. This is the basic pathogenesis, that how the hormonal imbalance can occur in patients who present with a polycystic ovarian syndrome. So this is just an overview. And similarly, this is the one, I'm just more focusing on this one. So you can see, if you are going to see a hair follicle, if there is testosterone or dihydrotestosterone, and it's going to androgenic receptors in different target organs of our body. If it's affecting the hair follicle, it can cause um, face, it can cause hirsutism, abnormal hair growth on the scalp. It can cause androgenic alopecia, acne. If it's going to affect the sebaceous gland, it can appear as acne and seborrheic dermatitis in few patients, and there are a few other symptoms, but we are just focusing on the cutaneous manifestation that usually happen with such patients. So the commonest one, which I'm going to discuss, is acne vulgaris. Acne is the commonest symptom that the patient present with polycystic ovarian. Sometimes the patient is even not well aware about that they are having any such symptoms, polycystic ovarian, but whenever we treat them and we investigate them, then we came to know that the patient is having polycystic ovarian syndrome. So acne vulgaris is the commonest symptom that usually appear on the face, sometimes chest and back. So it's not just the face that is going to affect. Sometimes the other body areas are affected with the acne vulgaris, and the peak age is about 17 to 19 year, 16 to 17 year in the females, and it can happen up to the age of 45 years or 50. So it's not just the teenage is going to affect with acne. If there is hormonal imbalance, the late age acne can present. So there are there is a specific spectrum of lesions of acne, how they are presented. Initially, it presented as non-inflammatory lesion. Non-inflammatory means some papule and comedones can appear. Then if we are not going to treat, it would end up into the inflammatory lesion. These are small pus-like lesions, and then nodules can appear on the face or back. And if we are not treating these problems, it end up with scar. So the early treatment is important. So why acne happen? Acne happen because there is excessive sebum production. There, and the androgens are responsible for excessive sebum production. And then because of excessive sebum production, there is increased keratinization that would lead to comedone. Comedone that commonly we are calling as open pores or closed pores. Similarly, bacterial proliferation, blackhead and whitehead, sorry. Similarly, if there is a bacterial proliferation, propionibacterium acne growth, that would lead to inflammation, and inflammation appear as pustules and sometimes scarring. So this is the picture that you are going to see. Um, this is the pilosebaceous unit. Small microcomedones form initially. If we are not going to treat, it would appear as open comedones and inflammatory lesion. And inflammatory, then you can see a lot of inflammation and inflammatory reaction appear, and it would appear clinically with papule or pustules. So these are initially microcomedones that you can see in the picture, the microcomedone, because there is hyperkeratotic lesions over the hair follicle, pilosebaceous unit. But then there is more comedone formation that appear on the skin as a comedone formation, then because there is accumulation of corneocyte over this area, now these are the inflammatory cells. Now the inflammatory process started. Clinically, it appear as papule or pustule, and then this is when the inflammation is very severe, it appear as nodule or nodulocystic type of acne. So acne could appear in different stages and different clinical presentation. So what is the non-inflammatory acne? So you could see these are blackheads or closed comedones. This is the initial stage when there is a small abnormal keratin deposition in the pilosebaceous unit. It appear as these type of lesion. Similarly, you could see these are comedones, open and closed, both type of comedones, and this is slight inflammatory reaction, papule. Clinically, inflammatory lesions appear as you can see the inflammatory marker appear over the pilosebaceous unit, and they clinically appear as papule, pustule, vesic, and sometimes the scars. And you can see the post-acne scars in the picture. This is the inflammatory severe acne, papules, pustule, inflammation, redness, widespread, and she excoriated over this area. And similarly, this is another one. This is called nodular cystic acne. You could see the largest cyst over this area. So this is called as stage 4 acne or nodular cystic severe type of acne. This is another one. This is a big cyst with some papule, pustules, and inflammation. Similarly, multiple nodules over the forehead. So we saw these different type of clinical picture. So it's because of increased sebum production, blockage of pilosebaceous unit that would lead to comedone formation and proliferation of propionibacterium acne would leading to inflammatory lesions, papule, pustules, and comedones. And all these processes are because of abnormal androgen secretions in the young or middle-aged female. So there are different treatment options. As a dermatologist, we just try to focus because if there is a not very severe acne, the patient present first time to us, we try to treat with topical therapy. There are different topical treatment options are available for such patient. So maybe either different creams, azelaic acid, vitamin A cream, benzoyl peroxide, topical antibiotics. So this is the first line. We just try to figure out that either these medicine are working or not. In addition, we also give vitamin A, that is isotretinoin, that is a systemic and topical retinoids. Um, the mechanism of action of these that they affect all the processes of acne formation, the pathogenesis, because it's removed the comedones, improving the activity of the sebaceous glands, decrease the keratinization, and reduce the inflammation. So this is the best treatment options available for the patient who present with acne vulgaris. In addition, the history of the patient is very important. While you are treating the patient, history and examination is important because we are going to see that there is just mild inflammation. Patient is not having any other symptoms of androgenization, like there is no other symptom, no androgenic alopecia, not hirsutism, nothing present. Patient is not giving the history of any abnormal hair growth or abnormal weight gain. So then we start with these treatment, either oral antibiotics or systemic retinoids. And whenever we think if there is any hormonal issue, then we ask the patient to work up for the hormonal assays and ultrasound for PCOS, because that is important thing, because sometimes the patient present, they took treatment, they have gone for laser therapy or other therapy for their treatment, but they with no effect. Means there is some abnormal hormonal levels that need to be treated. So hormonal therapy, we would refer for the patient who are not responding to such medication. Um, for all these treatment, we always advise the patient that 20% improvement occur in first 2 months, and 60% in 4 months, and 80% in 6 months. For the one which we are giving either systemic antibiotics, or in few we are giving retinoid therapy. So when we advise um, hormonal therapy, there are different hormonal therapies available. So what is the indication for the patient who came to a dermatologist and we want them to be on hormonal therapy because acne is not responding to conventional therapies? And acne is severe acne like nodular cystic acne, and sometimes there is a gram-negative folliculitis in the patient, hormonal imbalance along with polycystic ovaries is evident from the ultrasound. Um, in addition, patient is having severe psychological disorders, because as Dr. Aisha already mentioned, that these are the problems that are major psychological concern for the patient. Acne for a young girl, even for a middle-aged lady, acne is a major psychological and psychosocial issue for the female. Um, these are few options that I have discussed. These are the common topical or systemic therapy. But as a dermatologist, we have some other options that we do intracystic steroid injections for the patient who present with nodular cystic acne. We do sometimes cryotherapy, that is a liquid nitrogen spray for the cyst of acne. And if the patient is having scars, then we offer the microneedling. Microneedling is a procedure, and then we do the laser. There is specific laser for acne scars that is called as IBM YAG laser. So these are few options that but um, for all these therapy, we just work with in as a multidisciplinary team, because we can't treat such patient um, in isolation, because we need help from gynecologists. Sometimes we need help from endocrinologists. So, and sometimes we need help from psychologists. So as a team, we work together to relieve the symptoms of the patient. If the symptoms are very severe, patient is not responding, along with these, there are few advice we give to the patient that lifestyle modification is important, regular exercise, healthy diet, healthy activity, and avoid high sugar food. So these are few things that is important. Similarly, stress is a main factor that they need to relieve, because stress is a major trigger for acne and other hormonal issues. So this is another patient. This is one patient that I just want to discuss with you, who present with, she's a young girl who presented with history of shedding of hair with hair volume. She noticed that the volume of hair is reducing on the mid-frontal scalp. Otherwise, she was normal. She was not um, taking on any medication, but periods were irregular. And we tried to rule out other causes of hair fall. So what are the other causes? So you can see, sorry, I'm not sure. Just okay. So you can see examination. This is the central parting. You can see this is the wide parting over this area, and similarly, she was diagnosed as androgenic alopecia. Why androgenic alopecia? Because this is also called as female pattern hair loss. What is female pattern hair loss? Um, we call one is male pattern hair loss and another one is female pattern hair loss. Female pattern hair loss is not very common, but male pattern is very common. And usually a female pattern hair loss affects 6 to 12% of the women between the ages of 20 and 30 years. And the main difference between female and male pattern hair baldness is the frontal line is not receded in the female who presented with such hair loss. And the most patient with female pattern hair loss, they have normal level of testosterone, but can be a marker of hypoandrogenism in female. So this is the structure of hair follicle. You can see this is the structure of hair follicle. So sometime whenever the patient present with hair follicle, so it is important to know what is the structure of the hair follicle. This is the hair bulb. Now the new hair growth is from this area, and the hair cycle is comprised of different phases, and every phase have their different consequences. Like you can see, this is the growing phase. This is called the anagen phase. This is called the catagen phase, when the hair is detached from the hair bulb. And now you can see telogen. Telogen is a resting phase where the hair gradually going to detach from the hair bulb and it's going out. And now hair is completely gone, and now the new hair growth cycle is appear. So whenever we have hair follicle abnormalities, hair loss or something like that, we always need to find out what is the problem in the hair cycle, hair growth cycle. There is something abnormal over this area. Androgens going to affect the hair bulb. Okay, and then what they are going to do, let's discuss. Um, Whenever the patient presents with diffuse hair fall, along with all the other things, we are going to see that if there is acne or sometime there is no other symptom that we could point out that she's exactly having a polycystic ovarian syndrome, but we need to examine all the other causes. We need to rule out all the causes of hair fall, that what are the other, if there is a patient very stressed, if there is any other thing going on, or it's just because of some hormonal imbalance. We need to figure out, we need to examine the patient properly. So you can see this is a male pattern baldness and this is a female pattern baldness. This is called as Ludwig pattern of hair fall. Ludwig pattern, you can see this is normal now. Gradually, this is thinning of hair from the center, and from the center, the hair line is again reducing toward the periphery. And in this area, you can see the white parting. So in the male, you can see uh, this area, the hairline is receding, like this line is receding in the males, but in the female, the hairline is not receding in pattern hair loss. In the female, there is the hairline is intact, but the central area is going to affect mainly. So this is called as Ludwig pattern of hair loss. So why it's happened? Women with female pattern hair loss have low levels of circulating sex hormone binding globulin, SHBG, increasing the available free testosterone at the level of the hair follicle. Estrogen signaling can modify androgen metabolism at the level of hair follicle, and that affect the hair loss through inhibition of 5-alpha reductase. So if you examine the patient under the trichoscope is a type of microscope that we use to examine the hair follicle. So you can see these are normal hair follicle, 1, 2, 3 follicles. These are normal hair follicle, but if we are going to see a patient who present with androgenic alopecia, so you could see these are miniaturized follicles. The number of follicles are almost similar, 1, 2, 3. 1, 2, 3. Number of follicles are similar, but you can see they are thin out. So the terminal hair have been transformed into vellus hair, and then gradually the vellus hair shed off, and then the patient experience baldness. This one, the hairline is not receding, but over this area, gradually there is thinning of hair. This is the thinning of, and then with the passage of time, there is the more hair loss over this area. You can see the scalps. This is grade 1, grade 2, in grade 3 of female pattern hair loss. This is the similar. So history and examination, always take the proper history, because just to rule out if the patient is having polycystic ovarian syndrome, associated syndrome, what are the treatment options we need to opt for this patient. The history and examination is mandatory. Proper history, proper examination. In addition, family history of baldness is important. The risk of androgenic alopecia increase with a positive family history. As we have discussed, in men, the gradual receding frontal hairline is important, while in female, there is diffuse thinning of central scalp with preservation of frontotemporal hairline. What are the different diagnostic tests that we need to opt for these patients? So these are thyroid function tests, CBC, free testosterone, dihydroepiandrosterone. So these are the tests. A clinical examination, we need to pull the hair to see either it's how many hairs we have lost. Similarly, we are going to do the trichoscopy. This is a device that helps us to identify there are how many hair loss over the area. So treatment, there are different treatment options, combination of therapy that we go with hormonal therapy along with topical and systemic therapy. The topical therapy best available is minoxidil spray. We usually give to the end. There are few other different type of 2%, 5% topical solutions are available. That is helpful if we start these options earlier. But if we are late, then we have some options like, then we ask the patient if there is widespread in hair loss, then sometime in few cases, other options would not work. So these are camouflage, wigs, and these are nanofibers. And this is a patient who was treated with hormonal treatment along with PRP. PRP is an option that is work best with hormonal therapy. So if we treat the patient as a team with dermatologists, endocrinologists, then we would able to get the good results. So these are nanofibers. These are small fibers that can be used for male and female. These are small fibers that the patient spray over the scalp for the time being. It's a camouflage. It would increase the confidence of the patient. Similarly, hair extensions are available. Hair transplant therapy is available, and the platelet-rich plasma therapy or exosome is an option that is a new option that work well for the patient who present with uh, such type of problems. The last topic is hirsutism. Hirsutism is excessive hair growth on the body areas on a male pattern. Like it can happen on the nipple, on abdomen, on the face, and usually patient experience thick hairs. So the male pattern hair growth occurs inside where relatively high level of androgens are present. And it results from the fact that stimulation of hair growth from the follicle doesn't depend only on the circulating androgen, but also at the receptor site where the hair follicles are there, how they are receptive toward these androgens and sensitivity. Like you can see, this is a case of hirsutism. These are normal hairs. These are called as vellus hair, but because of androgenic effect, it has been transformed into the terminal hair. This is opposite that happen over the scalp. Over the scalp, terminal hair have been transformed into the vellus hair, but on the body, the vellus hair are transformed into the terminal hair. So the androgens play a key role in such virilization. Along with this, the important advice for the patient who present with hirsutism is avoid steroid creams, because if you are using the steroid cream, that would increase the hair growth over the face, because whitening cream, not the steroid, whitening cream. Most of the whitening cream, they have steroid in them. So the physical examination is important for us. Similarly, as I have discussed, if we need to identify all the causes, if the patient is having acne, androgenic alopecia, hirsutism, weight gain, acanthosis nigricans, or uneven skin tone. So this is the thick skin we saw in the patient who present with hirsutism. So in indication when we need to see a dermatologist or endocrinologist, because if the patient is not responding, patient is having excessive hair loss with excessive hair growth on the face. The growth is that much thick and excessive that even if the patient is having any waxing or something, then in 2 or 3 days the patient experience again the thick hairs. So laboratory findings, obese women with PCOS, abnormal hormonal assays, and ultrasound abdomen. These are the things that we need to figure out. And there are different treatment options available. Mechanical therapies, patient can go for waxing, for threading or something, but these are painful procedures. So the best is either electrolysis or laser therapy is the best option. Along, we advise the patient that if you want to opt for these treatment options, that you should continue your patient, your treatment, whatever your endocrinologist is advised. So we do side by side all these. These are adjuvant therapies. So the best treatment, laser treatment, is we usually offer is Nd:YAG laser. Nd:YAG laser, diode laser, these are different type of laser that are good for the patient who present with thick hairs over the beard area or body parts or nipples. So laser is a good option that reduce up to the 80% of the extra hairs. So if the patient is taking all these therapies or hormonal therapies, then it's important to identify that it is not just a magic. You started your treatment and you would settle down. It would take time, and therapy need to be continuous indefinitely. It's not just that in few months you just stop and you just want to see the response. So, for all these, it's important that which patient you are selecting. Patient selection is important after taking proper history and proper examination. So, so the important point take-home message is these skin signs are often the early indicator of PCOS. Early diagnosis and multidisciplinary approach is important to make decisions about the symptom relief and quality of the life. Timely intervention is important for the long term to prevent the long-term consequences of such patient. Thank you.
Thank you very much, Dr. Sadia. I think you have explained the insight of the dermatological manifestation of the PCOS. I think you have explained it in very much details, and I hope that the audience has gained some knowledge from this discussion. So I think we already have some question, and if you people have any question, you can put in the question and answer section. So, Dr. Aisha, I think I would like you to answer this question. There are a few questions in the question and answer box. There is a question which stated that ultrasound findings are enough to label PCOS in women with irregular cycles or amenorrhea, or criteria should be met. As in clinical practice, every second woman is labeled as PCOS with ultrasound findings of multiple tiny follicles, and these women don't have acne. Or I think you have already discussed this topic, but Dr. Aisha, I want you to answer this question.
So thank you very much, Salim, and thank you to our Dr. Veena, and also eventually asked this question. Remember, whenever you are having the criteria for that would be the right way to label somebody as PCOS, and then is the not only the criteria, you have to exclude certain conditions when you're labeling somebody as PCOS. PCOS is a diagnosis of exclusion. You need to be sure that the patient is having at least 2 out of 3, which are oligomelanism or anovulation, that will manifest itself as oligomenorrhea or amenorrhea or infertility. Similarly, hyperandrogenism or hyperandrogenemia, that will manifest itself as acne, hirsutism, or biochemical hyperandrogenism, where you have an evidence of elevated free androgen index or testosterone levels which are high, and polycystic ovarian morphology. But you have to have 2 out of these 3 criteria to be present at one point in time, and then you have to exclude other conditions which can give rise to similar clinical features like hypothyroidism, like hyperprolactinemia, like non-classic CH, and in select cases where you have any clinical feature that are suggestive of Cushing syndrome or a very rapid onset of virilization, where you would like to know that we are not dealing with an androgen secreting tumor. So be very careful when you're labeling somebody as PCOS, and while you are working them up, you can label that this might be PCOS, this is atypical PCOS. I would like to complete the workup before labeling her as PCOS. So do not label just on the basis of an ovarian morphology or ultrasound. You have to be sure that there is menstrual irregularity that qualifies, and I showed all those variable menstrual irregularity definitions that are used in PCOS. Similarly, hyperandrogenism or hyperandrogenemia is demonstrated.
Okay, thank you, Dr. Aisha. So there is another question. The question stated that a lady already using Dine 35 for the last 2 months without confirming diagnosis of PCOS. So how long she should be off the tablets before we can do the workup to confirm or refute the diagnosis?
Okay, thank you, Dr. Salma, that you have asked this question. And this is something that we will come across very often. A woman would be already given hormonal treatments and she's on hormonal treatment when she's presenting to you. So you need to stop hormonal treatment for a few months. Generally, it's recommended that at least 2 months should have been passed when you have stopped those hormonal pills, and then you can evaluate them with androgen levels or LH-FSH ratio that you want to look at. Remember, LH-FSH ratio is not something which is one of the diagnostic criteria in PCOS, but in women who have predominant amenorrhea, you need to know that we are not dealing with any kind of hypogonadism. That could be a hypergonadotropic hypogonadism or a hypogonadotropic hypogonadism. In that situation, LH-FSH study levels would be helpful. Otherwise, to check for their androgen levels, we have to again, because for a combined contraceptive pills, we're actually be working as anti-androgens as well. So you have to stop it at least for 2 months before you can do a biochemical record.
Okay, Dr. Sadia, I just want to ask you a question. You have showed a slide because we were able to learn something from you. You have showed a slide where there was a nanofiber treatment for the hair fall. So is it something new or is old or being used for the quite long?
No, and it's just a camouflage because nanofibers are small fibers, artificial fibers, and you spray on your scalp and then they just appear like your hair growth. And that unless you wash your hairs, it would be on your scalp, but it is something the one who are very conscious, or if someone is going to see the scalp is visible and they want to hide, they just spray it. So it's a quick remedy.
Okay, good. So probably we may need this in future as well. So I think I should move to the next question. So Dr. Aisha, there is a question by Duris Samin. Madam, which progesterone should be preferred in PCOS patient for withdrawal bleed and its dosage?
Okay, so as I mentioned that you would like to have withdrawal rate at least every 3 months. Don't continue with amenorrhea longer than 3 months in women with PCOS. For that, you can use either the norepinephrine, which is available by the name of Remote N. In Pakistan, 5 milligram twice daily for 10 days. And then when she'll stop the treatment of Remote N, she'll get a withdrawal rate. Other option would be digosterone. I think this is available by the name of Dupestone, digogesterone. This is something which is more favorable for women where you are suspecting that she might be pregnant. So a PCOS woman who is already married, is sexually active, and she gets amenorrhea, then giving digogesterone as a progestin for withdrawal rate would be a better choice because this is safe in pregnancy. So if she's pregnant, her pregnancy will not be at high risk because of your treatment. The best idea in women who are married or sexually active would be to get their pregnancy test done first, and if that is negative, then she can use either of the progestins. The other options could be the progesterone itself, the generic progesterones, which are available by 100 milligram or 200 milligram doses. Those are taken once at night for 10 days. Again, 10 days is sufficient, and it will, after stopping that progesterone, she will get withdrawal bleed. And another option would be methoxyprogesterone. Methoxyprogesterone is not available in Pakistan. It gets imported, but then it will be very costly. So very cheaper option would be using norepinephrine in these women.
Okay, so we will quickly take this last question for Dr. Sadia. The role of eflornithine cream for local application. So Dr. Sadia, if you could answer this question.
So, because some of the patient they can't afford, or they don't have the time to come for the laser therapy. So we usually ask them to use, or we use in combination with laser therapy. So that usually help in patient who usually present with thick hair. So I personally prescribe them for this cream. It's helpful to some extent, not 100%, but to some extent it's helpful.
Okay, so thank you very much, Dr. Aisha and Dr. Sadia. It was really a great presentation, and I hope that our audience has learned a lot of things from these two presentations. And Pakistan Endocrine Society has already been desirable to spread the knowledge of diabetes and endocrine across Pakistan. Considering this, we have already initiated multiple sessions, all these things. And as already Dr. Aisha told that Pakistan Endocrine Society has their annual conference from 11 to 13 of October in Lahore, Pakistan. So you all are invited in this academic conference. So regarding the presentation, this presentation will definitely be available on Pakistan Endocrine Society YouTube channel. You can take the emails of Dr. Aisha and Dr. Sadia from the Pakistan Endocrine Society official website as well. So I think Dr. Aisha, Dr. Sadia, with your permission, I would like to end this session. Thank you very much.
Thank you very much, Dr. Salim, for a wonderful moderation. And thank you, Dr. Sadia, for your kind presence and valuable talk for this session. Thank you, Dr. Sumaira Jabin, for leading the PCOS awareness campaign this year. And I'm really grateful to all the audience and our IT support, Anas and Harun and Atif, for helping us with all these webinars and sessions. Thank you, Dr. Salim, for a wonderful moderation. Thank you very much.
Thank you. Thank you very much. Allah Hafiz.
Allah Hafiz. Thank you.
Allah Hafiz.